My name is Egbert Schillings. I'm the CEO of the World Innovation Summit for Health. I want to thank you all for joining us here in the face of stiff competition downstairs. You have chosen to be here despite canapes and coffee in the gallery. And I'd like to think that's because you care about two things. One is learning from international collaboration, which ultimately is the reason anybody would come to a conference like WISH. And also, I assume, and I know from some of you in the audience, because you care about patient safety. So we're going to bring both of those things together. So we hope that we can make it worth your while and be the replacement for coffee by keeping this very snappy. This is a policy briefing. This is a shorter session. It's a fast and furious one. But it is one that's very near and dear to my heart, because this is in many ways a family affair. We are going to talk about the experience of health systems who decide to, well, to put it flippantly, put their money where their mouth is, because there's almost no health system in the world that doesn't have to say at some point that they aim to be world-class. There is a PR brochure somewhere where somebody says we want to be a world-class health system. But very few health systems actually decide to take the step and say, well, how do you know you're world-class? You only know this if you actually compare yourself to others. If you lay open what you're doing right, where your challenges are, and then to see how you stack up. And that is ultimately the explanation of why it is called the Leading Health Systems Network, because a group of systems got together and decided that's exactly what we're going to do. Because transparency is important not just in patient safety, but in any type of performance improvement. So very briefly about the background of this. This program originally started actually at McKinsey, and there are people in this audience who gave birth to this program in 2009. It then moved over to Imperial College and is a collaboration between the World Innovation Summit for Health and Imperial College. In Doha, over a year ago at the last WISH, the network was reconstituted to focus on patient safety. It had looked at other issues beforehand. And what we want to share with you is what happens when health systems decide to say, here is how we approach reporting harm. These are the sources that we look at. And the group that you see here up on the stage that I will introduce to you in just a moment is a group of leaders that have decided to take that extra step. So allow me to introduce the distinguished panel briefly. We have Professor Ibrahim Jenahi. He is a senior consultant, and he's also the head of pediatric pulmonology at Hamad Medical Corporation right here in Qatar, and also the executive director of research at Hamad Medical Corporation. Jonathan Gray is the director of Coahuatea at Counties Manukau. Counties Manukau is the health system that serves the population lucky enough to live in Auckland, New Zealand, the largest city in New Zealand. We have Preeti Kaur from Apollo Hospitals. She's the lead on quality and special projects at Apollo Hospitals. Apollo is the largest private hospital chain in India and in the region. And then we have Mary Achenhusen, who is the president and CEO of Vancouver Coastal Health, which is another beautiful spot on the map, because that is the health system taking care of the population in Vancouver in Canada. And then we have Dede Thompson, who is a fellow at the Institute for Global Health Innovation at Imperial College in London, and very much the author behind this report and who pulled all the research together. So, before we go into the details of what we found on this panel and the topic of international collaboration, we should probably start with just a few words about the network itself. Dede.
Great. Well, thank you very much, and thank you all for joining us. As Egbert mentioned, since we relaunched at WISH 2015 last year, we've been focusing on the topic of patient safety. Our main piece of work has been with 8 health systems, 3 of whom are represented here on stage, looking at information for patient safety. So how do providers actually assess the safety of the care that they provide? For those of you who actually work in patient safety, you realize that that's not a straightforward question. You can learn all of the details in the reports, but in summary, we created 2 questionnaires to assess how this information is used. So which sources do you use? Do you use patient-reported data, staff-reported data, administrative data, case reviews and audits, or liability claims? We then asked, which specific metrics do you review on a routine basis? And we asked this across care settings, from mental health to primary care to acute care. We also did a deep dive on incident reporting, looking at characteristics from uptake to usage to information capture, and finally to how you use this information for learning and improvement. And we did this in the spirit of comparison and learning. So we in no way are ranking health systems. We're not saying that health system A is safer than health system B or better than health system B. But what we really wanted to do was provide a comparative overview of how people assess patient safety and then hopefully come up with some actionable recommendations for all of the health systems to use. So not getting too much into the weeds of the report, but just an overview of a few of our key findings. We found that information is quite limited outside of the acute care setting. Perhaps this isn't overly surprising, given that most early studies on patient safety focused on hospital errors, so subsequent research was also focused there. Mental health and primary care can also be seen as a bit less risky than acute care, again, leading the focus to be there. And finally, backed up by the literature as well, there's a lack of clarity and consensus on the definition and types of incidents that occur outside of acute care. One particularly startling study from the UK, for example, was a survey of GPs, and it found that most of them didn't know what to report, how to report it, what constituted a sentinel event in primary care, or even if they themselves were responsible for patient safety in that setting. So I think this is also reflected in the number of indicators that are routinely looked at. So within our sample, for example, there were 3 to 4 times as many indicators in acute care than in primary care or mental health. But even within acute care, where we had the most indicators, there was really a focus on outcomes, so things that have already gone wrong, rather than looking at structural or process metrics and the characteristics that might have led to those mistakes happening. But again, perhaps this isn't surprising. Outcome metrics are more objective, they're easier to measure, and they're directly associated with harm. They're also often required by law to be reported. So many systems are required to publicly report sentinel events or specific types of infections. So after we looked at all of this, we combined our survey with a review of the literature and also some expert input, and came up with a range of recommendations which are highlighted in the report, which I hope was outside, but if not, apologies. So our recommendations ranged from a call for more research, not surprising, given that we're a research organization. But we really need to learn which metrics we should look at to actually drive improvement, what's important to look at, and building the evidence base around that. We also recommend tracking consistent metrics year over year to identify problems within organizations. And finally, the ever-present recommendation for creating a culture of openness and not blame, a place where really every employee can feel like they own the responsibility for patient safety.
Thank you, Dede. So 17 health systems are members of this network. 8 out of the 17 self-selected into saying we are going to share our information, and we're going to share it with not just the other members of the network, but actually with the public. So let's begin. This is globe spanning in India. So Preeti, Apollo Hospitals is a private sector entity, and the others that are part of the group largely are public sector providers who, well, sort of own a population. So when it comes to patient safety and taking a systems view at it, does it matter that you essentially don't own the populations in the same way?
Yes, and I need to inform you that for us, the journey of quality in patient safety began in the year 2005, when Apollo Hospitals at Delhi became the first hospital in the country to be JCI accredited. So that galvanized the healthcare industry in India. Thereafter, Apollo Hospitals worked with the government of India to formulate the NABH standards. The standards, these are basically, the NABH stands for basically the National Accreditation Board for Hospitals. So they accredit all hospitals across the country, and that's a national system. And today, I need to tell you that there are 30 hospitals in India which are JCI accredited, and around 400 hospitals in India which are NABH accredited, and many more in the pursuit. We, as Apollo Hospitals, did not stop there. We went on beyond the levels of accreditation. We wanted to ingrain patient safety into our very system, so we implemented TASK. TASK stands for the Apollo Standards of Clinical Care, and this consists of a series and sets of platforms which are there for patient safety, reporting of clinical outcomes, sets of policies and procedures which are uniformly implemented in all of our 64 hospitals. We check compliance, and we validate the implementation as well. So just like TASK, we implemented another platform, which is called the Apollo Clinical Excellence Platform, the ACE platform, which is meant for the healthcare community, other than Apollo, outside Apollo. So we reach out to healthcare providers who are mostly in the interiors of the country, the small hospitals and the nursing home. We take them along with us. We teach them patient safety. We hold workshops for them. We have given them standardized methodologies, the process indicators for patient safety, and we handhold them and we teach them. Apart from this, one important platform that we hold each year is the International Patient Safety Congress, which is a very much sought-after event in India. We invite thought leaders from across the world to share their ideas about patient safety, only for the benefit of the healthcare community in India. And this is all that we're doing for promoting patient safety in India, not only just for the private sector, but also for the public sector.
All right. Thank you. So Apollo Hospitals has in their DNA transparency, holding itself to standards, because I think you used the word standardize at least 3 or 4 times. So you take a very solid approach to that. Now, Mary, Canada is a famously inclusive and transparent country. You yourself run a health system providing care to 1.3 million people, roughly. And by background, you're an engineer who will appreciate what Preeti just said about standardizing things and creating a system around it. But you work in an industry that famously is, well, the most complex that one can think of, at least that I can think of. So as an engineer coming into a health system of that scale and complexity, what has that journey been like?
Right. So as an engineer, I probably look at it a bit differently. So yes, I love the data. I love comparing the data. I think as a public healthcare system, no problem being transparent with the data. But I am an engineer, and I'm an industrial engineer, which actually means I concentrate on processes, efficiency, et cetera. So while we do lots of comparisons across all through Accreditation Canada, we're always comparing ourselves to others. Through this network, we compare ourselves. In reality, we know that this data is, in many cases, not comparable. So when we look very good, we're skeptical of ourselves. When we look very bad, we're also skeptical. So we go through a lot of processes trying to figure out how do we balance the need to run a healthcare system, the need to transform a healthcare system, with the need to look at the data that our public is looking at and determining where we have the gaps and where we need to focus our efforts. So we do annual scans, of which the LHSN is a part of, that we look at some of that data as well as lots of other comparators and decide what are those big items that really will make a difference, that we're confident of the data and that it's a big enough impact on our population that we must pursue that and be as strong as we can be. And linking back a little bit to those of you who are in the Accountable Care Organization meeting, we use that concept in terms of with our leaders. It's basically pay for performance. So you get paid based on your infection rates, paid based on your hospital-acquired pneumonia, paid based on falls, et cetera. So we really link what we think are the most important indicators of safety or the most measurable to what our chief operating officers get paid for performing, and it's penalized as well. We had questions in another session, how do you penalize, what's the stick? Well, there actually is a financial stick if they don't meet those performance rates. But because I'm an engineer, and I actually grew up in a manufacturing environment, it's not good enough just to measure, and in such a complex system, it's very hard to make changes. I often cringe when we come up with, okay, what's the resolution or what's the correction for a problem we've had? And it's often layering another process on top of a very complex process. And we know that we don't have the ability to measure the compliance. We know that the chances of layering another process, which is often paper-based, often a little bit additional education, isn't necessarily going to have a lot of impact. So we balance that with really wanting to focus on the root cause and how we're going to correct the root cause, which, many times there's systems issues like closed-loop medication. That's really how you will reduce medication errors, as opposed to having nurses double-check what they're giving. Bringing in the electronic health record, which will help us to not only guide clinicians around protocols for care, but also be able to measure compliance and see opportunities for education where that doesn't happen. So really keeping that balance between what we need to report on a regular basis and what are the big dot measures for safety that we need to make sure we're excellent at, as well as putting a lot of effort into that root cause and making sure we're actually changing the system so that it's easy to do the right thing as opposed to the complex system that you just articulated that we have today. Because one of the interesting things of the report that I think the audience should know is, and the two data points you showed, is somewhere between 14% is the compliance for reporting of safety issues, so only 14%. So we know so little about what's actually happening in our hospitals and community settings in terms of patient safety.
Thank you, Mary. Jonathan, so you're the director of Coahuatea, which is an entity at Counties Manukau that at least partially is designed to source innovation and to link up with other healthcare systems. So joining an outfit like LHSN and comparing notes in a very transparent way, how do you use that then internally for your own advancement in the health system?
Thank you, Egbert. Firstly, can I just say it's a real pleasure to be here, and I just need to announce that my luggage didn't make it, so we need a few engineers to help us, I think, with the process on that particular airline, which I won't name, hence how I'm dressed. My apologies to all of you.
Thank you for not naming the airline.
Simply put, Egbert, LHSN gives us something very, very valuable, and that's access to global innovation. Coahuatea is a wonderful organization, and the name itself was gifted by our indigenous people in New Zealand, and it means first light. That time at the beginning of the morning, I think many of you will recognize from this morning, that very, very early time in the day when the light is just about to come out and you sort of feel anything is possible, even those really, really difficult things. And I think to tackle those really difficult problems, we need to have organizations like Coahuatea, like this amazing gathering of people that are curators of innovation. And crucially, I think some of our systems, some of those curators need to be embedded in systems, so they're right at the heart of the problems that we need to fix. So Coahuatea is embedded in a really, really challenged system with many of the issues that you're facing. We like to think of it as a system that's culturally rich, but also, sadly, disease-rich. And to be successful, Coahuatea needs access to that global supply of innovation. It can't survive on just its own awesome work. It needs access to what's outside. And LHSN is that partner for us. I was thinking of a few sort of pictures as I was thinking how to talk today. And for me, LHSN is a force multiplier. I was thinking that what we get from that is that one good idea goes to many people in the network, but equally, each of us in the network gets many good ideas from the whole. So I think of it through the lens of LHSN, that Coahuatea can act as a steward of innovation, a concierge, providing and sourcing ideas and workforce solutions that are needed for success in my own system.
Thank you, Jonathan. Professor Ibrahim, so HMC, Hamad Medical Corporation, which is the main provider on the public side here, is part of this network. It is part of a very dynamic health economy here in Qatar. It is part of a well-resourced health economy here. But before we went up on stage, you said that you want to talk about fragility in the system, which is quite striking. I'm just going to let you run with that. What's fragile?
Great, thank you. Well, thank you first for inviting me to be part of this panel and part of this discussion. I'm going to focus on fragility because I think that's what we have been very much interested in the last 2 years or so since we've started exploring how we can sustain a quality health delivery in the context of fragility. So in our understanding, fragility can be in any context, in a context of affluence or poverty or any other context. Fragility, by its wide meaning, means inability to sustain something in a quality way. So attaining accreditation, which means you attain certain level of quality, whether that's accreditation of your educational system, accreditation of your care delivery, accreditation of your administrative system, your research. These different accreditation standards assures a certain level that you have attained. But the biggest challenge is how you sustain it and maintain it and go on with it and innovate and build on it. So to start with, in a context of affluence and a context of well-resourced center, well-resourced system like ours in here, obviously achieving certain level is a challenge, but it's not the biggest challenge. Because as long as you can resource it, as you bring in people, you bring in system, train people, you always can attain it. Maintaining it is where you will start battling with fragility. So if your system is not deep enough when it comes to human resources, intellectual resources, innovative way of funding your programs, then you are in a context of fragility already. At any given time, any well-developed system can go into fragile context if that sustainability is lost. And this merits further discussion, which might take a lot more than just a little forum in here. But this is around this sort of concept. We've been very interested when it comes to this context of well-resourced center. On the other hand, we have explored further, how do we take a good system, a quality system that is well structured, and take it to a completely fragile context from the level of external fragility. So you've got internal fragility in the health system itself that I just sort of alluded to, but then you have external fragility which comes from the whole ecosystem that supports the health system, including fragility in the context of inavailability or scarcity of funds, instability of political system, instability of even geographic challenges, like some of the places where some of the global places that you go to, and it's very difficult to even build a hospital in that place. And there are people, humans, who are living there. So we came up with the concept, well, actually, the initiative of SALI, Save a Life Initiative, which started here in Doha, but the goal is global. That initiative basically focuses on sustainability and delivery of quality health care that is sustainable in fragile context. To be able to do that, obviously the challenge is humongous. You are going against so many odds when you are taking it to a context of complete fragility. So the first step was to identify and define what is the standard that we are going to benchmark against. And then you come up with 3 different domains when it comes to healthcare delivery. You got the quality health with all the KPIs that indicate quality health, whether it's hospital-acquired infections, malnutrition, infant mortality. There are these different, obviously, KPIs and indicators that would indicate how good is your health quality. And then you have the sustainability part, which basically requires leaving people and resources behind when you leave, and it can sustain itself. So training, education, formal training that goes alongside the healthcare delivery. The catalyzer of all this is research. If you build on assumptions that are not supported by quality data, you always are vulnerable to assumptions that are subjective, and then that creates fragility by itself. One of the biggest challenges you find in some of the developing countries, and by the way, developing countries doesn't mean poor or rich. Affluence is not related to development as far as I'm concerned. So you could still be in a developing country and you are very affluent. If you don't know how to use those resources, obviously, you go into that sort of development. And you can be developing countries for the rest of the life of this earth. In any case, so research that is based on real data from the ground, so bottom up. One of the challenges that a lot of the agencies that are interested in helping humans through some of the UN agencies, that's including UN agencies, they'll have to work from top down. That hits some of the walls. One of the biggest challenges, actually one of the biggest reasons why we have fragility in some context is corruption. And that's where corruption can create fragility any place, anywhere, regardless of what sort of environment you're in. So that some of the challenges that some of these agencies have, that they'll have to work through the existing system. And some of those existing systems might be corrupt systems, might be infected with this corruption. So it doesn't trickle down into where it really matters. So in SALI, what we decided to do is to match that and work in collaboration from the top down. Agencies are all there. We do bottom up, and then we meet in the middle. We do need a catalyzer for that, and that catalyzer, initially the thought was that, well, we're going to get the private sector involved because that would be a good PPP. And obviously, it is not, because private wants to make money. And in the fragile context, in general, unless you really drive it so meticulously, you don't make money. And therefore, there is another group of organizations who are interested in doing this and not making much money. Actually, their mandate is to deliver this care, and they are mandated to deliver it to the right people, and those are the NGOs.
Professor Ibrahim, you have given the audience a lot to chew on. You had me at fragility, then you throw in corruption. I think we need to pull up for a second, because there is a lot for the audience actually to sink their teeth into. So it's impossible to summarize, but what we've heard so far is standards are necessary, but they're not sufficient. When it comes to patient safety, all health systems are cobbling together the information to get a picture. We don't actually have enough. And resources, you can throw them at a problem, but they're not going to fix it. So that's already a lot, and I'm conscious of the time and the fact that we need to bring in this audience. So we have a wonderfully diverse audience just from who I can see through this blinding light. So I want to go to questions, because there is so much, we want to make sure that we fit that in. So we have mic runners here, and if I could see anybody who wants to ask a question, from corruption and fragility to standards to international accreditation and training, there is everything on offer here today. Way up there, way in the back. The microphone is coming to you. Thank you. If you could say briefly who you are and what your question is, very succinctly.
My name is Paul Barish. I'm a clinician and researcher from the US. Thanks for this very interesting session. I want to particularly focus on fragility, or perhaps the opposite of that, which is resilience. So we have a variety of tools that come from non-medical industries, like high reliability organizational literature, that gives us particular tools for assessing organizational readiness in environments where the sand is fickle and ethics are fickle and conflicts of interest are fickle. So here's my question to the panel. How can we use these organizational models, like high reliability, adapted to healthcare, as a way to enhance both internal and external fragility?
It's an excellent question, and last year we published a report at WISH actually on systems thinking and patient safety, and we looked at what are the out-of-industry examples that you can apply. And we decided to go the extra leap. We actually decided to go to the industry that takes lives rather than creates life, and that is the defense industry, to see how do you create high reliability on nuclear submarines so that you don't have a meltdown. So it's a fantastic question, and who on the panel wants to talk about those models and how you apply them in your setting? Who's volunteering to take that on?
You know, I think I'm the suicider here, so I'm in. I guess what we would be open to in the healthcare systems is open to any model that works. At the end of the day, different sectors need to learn from each other's experience, as you rightly said, but that learning from the defense industry is very important. As a matter of fact, in our model, we based it on the defense model as well. It's the systems of system and the wave management, all the different system engineering sort of concepts were utilized to build the new model that we are talking about. The SALI model is built on that. So it has all these components that are implemented in different industries, and it has track record of proof success. So I personally think that it's an open market. We go and select what sort of pieces that we need to build this custom-made sort of system, I would say.
Mm-hmm. Well, I'm continually struck that we actually talk about these concepts still that other industries have been talking about and implementing for decades. Tomorrow night, my son gets on a flight. He is 10 years old. To fly from Doha to Frankfurt and on to Hamburg as an unaccompanied minor. And it's his 17th flight that he's doing on his own. I feel relatively relaxed about him doing that. I would never let him go to the hospital or to see a doctor unaccompanied. There is a checklist in the cockpit. I have full faith that the systems of systems are working. Mary, you wanted to come in on that.
I mean, I think that's really the point, is we need to find the right balance on how much we hardwire into the system to take away basically the discretion, because we know more and more about what works and what doesn't work. And we know more and more that best practice is changing every week, every month, and that practitioners can't keep up with that. So how do you gracefully embed that in the system so that clinicians are given that basically artificial intelligence in some cases to say, this is the best way to do this. Now, you as a practitioner may know better, and that's okay, but we're going to nudge you in this direction, and we're actually going to measure your results. And if you choose not to go with what is considered to be best practice, because we're humans, right, and we're treating humans, and best practice might not be appropriate in every case, but we're going to start and look at how the outcomes are, and where we're getting the best outcomes. And we know so often, even though we may not want to admit it, that machine learning and those kind of things are starting to get better results than humans. But that's not the way our healthcare system grew up, and that's not the way we've been trained. That is the art, the art of medicine, and there's a lot to that. That it's a human science. We want human touch, and yet we're finding more and more the science is quite straightforward and can be hardwired into our system.
That is the voice of an engineer running a health system, I might like to think. And let's take a question over there. We have a question from Mike Durkin, who leads on patient safety for the NHS in England. Mike.
Thanks, Egbert. Some fascinating discussions going from resilience to fragility. One of the elements that came through strongly for me in our session on the behavioral insight session, and also Julio Frank mentioned it as well, was the impact of leadership in any system change. And so I'm struck on the machine learning piece here. So I'm wondering what the system has learned, or what the individual constituents of the systems are learning in terms of what are the metrics on leadership that you can start to deliver or start to understand, so that we can start to measure the impact of leadership, and whether that's at the concept of the team, which is the patient and the doctor or the nurse, or the hospital or the system, or nationally. I'm just wondering how you can start to gauge and measure leadership impact. Thank you.
I'm going to take the liberty on actually directing that question, because, Jonathan, I know that you have committed yourself to turning leadership development into a science, so you should know a thing or two about how you measure it. It's an elusive quality, and people will disagree about what actually constitutes leadership. How do you approach that?
Thank you, Egbert. Thank you, Mike. Two things I wanted to say about that. One, I wanted to link it back to Paul's point, and Paul was being a bit mean there, because we all know Paul is one of the world experts on the question he asked. And I would just deliberately deviate and say, I think there's something in the leadership question and something in the resilience about the resilience of the people themselves. I just flag up that we can go for frameworks, we can go for all of those other tools, but I'm increasingly worried and concerned about the resilience of people. And the opportunity for us to work in ways, whether it's mindfulness or whether it's building resilience into our leaders and our teams. So I think there's a lovely link between Paul's question and Mike's question around individual resilience as a way of managing that. But leadership, At our last forum that Egbert was able to join us at APAC, we launched an initiative called Climb. We were working, I was lucky enough to present with Edmund Hillary's son, the idea that leadership has probably plateaued, but not at the top of the huge mountains that we need to climb. So I'm right with you, Mike, in that we need to look again at leadership, respect the work that's gone on I think often randomly, as drawing together groups of people to attempt really difficult problems, and as probably getting up small mountains but not up the big mountains. So I'm with you around metrics, but I think we need to find a new way of tackling the huge problems, and I see the beginnings of that in WISH, where we've got fantastic groups of fellows coming together. And before we get into trying to measure what it is we're doing, I'd just like to make an appeal that we look to join up the fantastic work that's going around the world. The fellows in your system, the fellows in WISH, the fellows in New Zealand. There was a reason that they only climbed Everest in 1953 with a beekeeper from New Zealand, a travel agent from England, a Gurkha commander from the English army. There's something hidden behind all of that that says there's an extra level that we're not addressing at the moment. So yes, let's look for the metrics on what we currently do, but let's set the aspiration even higher and join up those leadership groups around the world. A worldwide collaboration to generate the next set of leaders that can climb the highest mountains. It'll be someone from your system, someone from here in Qatar, someone from New Zealand who can tackle those really high, difficult problems.
So Mike, you've got your metaphor for you. It's Mount Everest that we're climbing here. I hope that satisfied you. How about another question from the audience? Way in the back again.
Hi there, I'm Leslie Thompson from Accreditation Canada. Really enjoyed the presentation, so proud to see our colleague from Canada up on stage as well, Mary. I wondered about one of the features that I was missing from most of your comments, and that is the role of the patient in transformation and in the learning. And I wondered if members of the panel could speak to your thoughts and experience on involving and engaging patients in a meaningful way in the journey ahead. Certainly it is, I think, an ingredient that's probably been missing from a variety of the sessions through WISH. This is my first WISH, but there's that part is missing for me in the conference so far. And it's an area that I'm passionate about, as is my organization, and wondered if you could comment on that.
Thank you. Actually, part of the report and in the questionnaire for all of the systems was how much information on harm comes from patients. Is that one of the primary sources of your information? And the answer was, well, not much. So who would like to address how you involve the patients? We always talk about being patients as co-creators of their own health when we look at population health. But as prevalent as harm is in the hospital, I think if you walked into any emergency department and you asked people how likely they think it's going to be that they themselves will suffer harm, they would be very surprised, because people go very trustingly into that environment and think nothing bad will happen at all. So, Professor Janahi, you were shaking your head and saying, well, maybe we don't do a good job of that.
No, I don't think we do enough of that, and we must do much more in involvement of patients at all the levels. At the end of the day, we surrogate for the patients and assume that that's what they want, and that might not be. We assume that they are feeling comfortable with the system that is providing whatever care, and then we don't verify that, asking them. So I do think that we failed so badly when it comes to involvement of patients at the different levels. I think definitely we need to involve them more at all the levels, care delivery, their expectation, their comfort, how much they trust the system, how much they don't trust the system, and these are all linked.
And maybe that's where some of the out-of-industry models actually fail us a little bit, because tomorrow my son will not be expected to report to the cockpit the position of the rudder, but we do ask the patient and the family members to give the care team feedback on how safe they feel and what they think is going on around them. So healthcare is still a separate beast, and we're not doing particularly well on doing that justice. Mary?
I'd say the other piece, if you look forward, and again, it goes to hardwiring the safety into the system or hardwiring the patient voice into the system. And that's really taking healthcare into this modern age where we as consumers are quite empowered. And we know in healthcare, we're still quite paternalistic. We've talked about that in some of the different sessions, how, what can you expect from a patient or a customer? How much do we do for them versus they have to do for themselves? And so that all goes to, how does a patient become empowered? Well, they have access to their own health record. They have ongoing access to clinicians. They're leading the show as opposed to the provider silos that we have now, which are somewhat inevitable because that's the way we're set up structurally and that's the way our health records are, et cetera. So I think as we move more to a patient-empowered scenario where patients are able to access their own information, they're able to access their own diagnostics, sometimes actually perform their own diagnostics as you go out 5 years, I think that will be a strong way to empower the patient and make sure their voice is out front as opposed to the provider voice, which is too often the proxy for that.
We have time for one more question. This question comes from Australia, from Pradeep and Victoria. Victoria itself a long-standing member of the Leading Health Systems Network. Pradeep.
Thank you very much for that, Egbert. So we've talked a lot about patient safety at the clinical end, talking about systems, etc. I just wonder, in light of the keynote we just heard prior to this session, any observations on how, what changes you're seeing in medical education? I mean, we've talked about leadership, resilience, but often that's at the coalface when people have graduated, they're working in the field. But do you see changes? Do you see the medical education system keeping up with this debate about patient safety?
Excellent question. We have two medical students in the front row who are vigorously nodding their heads at this. Who wants to take that on?
I'm sorry, I'm taking more time than I'm supposed to, but I have a passion for this. Being the program director for a good number of years, I think that our education system in the medical field, medical education field, we are lagging way, way behind. The patient expectation, the way the medicine is being practiced, or will be practiced in the very short period of time is way ahead of the medical education curricula, or the structure even. After a very long period of time, we came up with PBL, problem-based learning. It's almost obsolete now because the way the medicine is practiced in this era is totally different than the way it was practiced just 5 years back. Now we're talking about personalized medicine. We are talking about technology being an integral part of your practice as a practitioner, as a health practitioner. You can't be not aware of the technology around you. You can't not be using them in your daily practice. And medical school do not teach that. We always say that all the kids know how to do this, whatever software better than us, but shame on us. We're supposed to teach them, isn't it? So I think that, and I've discussed this in several different forums as well, we do need to reform our medical school curricula. Same goes for all the other health practices, the nursing and the others. We do need to reform it in a way that is up to par, up to the standard, the current standard and the future standard. Personalized medicine and all what it goes with it, data management, computational biology, all that needs to go into your curriculum. At least we as physicians need to be aware of this lingo, the terminology, the way it works. We can't be so alienated to this that our patients are ahead of us when it comes to that. I have, as a practitioner, when I come to my clinic, and this happened to me several times, where a patient brings in a genetic report about his or her genetic analysis from somewhere, these commercial labs. I don't even know what is that all about. I don't know even, all I see is some colors and dashes and dots. That's all what I see. I've not been taught that. So I think the medical school is not really running the speed that it needs to run to be up to par. That's my take.
Thank you. Preeti.
So that's true for patient safety as well. What we believe is that patient safety should be taught as a subject to the undergraduate students too. Because healthcare cannot be rendered unless it is safe. It is as important as giving healthcare to a patient. We can't give care to a patient unless we know that this is the right patient to whom we are caring for, whom we are serving. So I think the medical colleges should really upgrade their systems of teaching, and we need to inculcate patient safety as a part of the curriculum right from the start, and need to teach them because they're young and they need to understand patient safety.
The question on medical education, and the same extends, of course, into nursing, clinical pharmacy, and everybody else on the care team, allows me to be a little bit self-serving, because I would invite all of you, and especially you, Pradeep, to go to the impact zone down below, because we actually brought a patient safety academy for pharmacy, medical, and nursing students to Qatar this year, thanks to the initiative of Rabal Turjaman, who is a medical student here at Weill Cornell. And what I was struck by this was a 4-day learning where people were inducted into the discipline of patient safety. And at every single table, the conversation was, I've never heard of this in my curriculum, and I've actually never sat at the table with nurses or doctors or clinical pharmacists together learning anything at all, never mind patient safety. So it was a very powerful statement, and tomorrow I have the wonderful privilege of knowing what the closing session actually is. The closing session will be focused on building capacity, especially in the young generation on that one. So I hope you will all join that, because the Minister of Public Health of Qatar will be hosting that together with Don Berwick. And that allows me, because I know we're a little over time, to actually ask a closing question to the entire panel, and it starts with Don Berwick. 2 weeks ago, following his Twitter feed and that of IHI, as all of us should, there was a short clip, and it was entitled Patient Safety Fatigue. So you gave the example of sustainability and resilience, and he was asked the question, a lot of people are saying, well, patient safety, we've been doing that for a long time. Jack Cochran is here, and many moons ago I worked at Kaiser Permanente, and I remember when the next hand-washing campaign was launched, people would say, been there, done that, have the t-shirt, did I not do that 25 years ago? So the sustainability, and Don's answer to that was, to me, patient safety fatigue sounds like breathing fatigue. How can you ever stop doing that? So sustainability is also sustainability of actually remaining focused on patient safety. So what is the role of comparing yourself to other health systems, sourcing innovation from around the world, creating metaphors like climbing Mount Everest in keeping that going? I know that this network is not done, and maybe, Dede, you will talk about what the next, base camp is on the way to Mount Everest that you're engaged in through this network, so that this fatigue doesn't set in.
Sure.
You're welcome.
Well, what we'll be doing next, and what we're in the middle of doing now, is a module on patient safety in maternity care. So we're actually comparing outcomes this time, not just comparing how we measure outcomes, and we're combining that with a patient safety culture survey, so we can really understand how and if patient safety culture affects outcomes. And looking one step beyond the horizon, somewhat within the patient safety realm, but also very much tying into what Dame Sally was talking about earlier today, we're going to be focusing on antimicrobial stewardship at the health system level, and comparing how people do that around the world.
So this is where the teeth come in, so there will be outcomes data, which should raise everybody's temperature a little bit. Mary, how do you sustain the interest in patient safety at a system level?
Well, looking at the system levels, there's patient safety, there's access, there's patient satisfaction, there's quality. So it's, that is the challenge I spoke to a little bit at the beginning, is you have to balance it all in a time when healthcare dollars are more and more constrained. And we're asking more and more of our clinicians, which goes to how long will they remain resilient? I mean, they're hugely compassionate, they're hugely hardworking, but how long can we continue to put more pressure on that system, which really leads to why I think we need to use technology more, why we need to hardwire it, because we can't depend only on humans that are working as hard as they really can to avoid errors on an ongoing basis. Maybe not the answer you wanted, but that's the engineer's answer.
Brilliant. Preeti.
Sir, I would like to repeat Dr. Peter Pronovost's words here. He says patient safety and quality is actually love. It's love for our work. So if we are motivated ourselves to do patient safety and quality, we can invigorate our teams to do well and to achieve our goals. And we can, really serve our patients better and give them safe care.
Thank you. Jonathan.
Thanks. Two very quick responses. Number one, I think I see a lot of that fatigue come when people lose contact with what we're doing it for, when we lose contact with the patient story. A great colleague of mine is in the room, David Grayson, and he always brings that skill of linking it right back to the front line, to the things that brought us into this system in the first place. The other thing I would do, linked to love, is within these networks is hope. And that, to me, also energizes, and that's something we've learned by lurking on the edges of your LHSN. We constantly learn so many fantastic examples that give us hope. So I think connection with the front line through real frontline practicing clinicians like David, and hope through the wonderful examples we see in the network.
Ibrahim, it's building to a hopeful crescendo. Take us home.
So the hope is always there, building resilience in the quality systems of any health system, and incentivizing people who buy into the new culture, or the culture of quality that is like breathing. And losing that means you're not alive. You got to keep it going. And we are all here to make sure that the patient is safe, and we should be happy that we're all talking about it now. It's becoming part of our DNA. So the hope is there. There's a huge light there at the end of the tunnel. I think we are there.
Thank you. I realize we're the only thing standing between you and a much-needed cup of coffee or a soft pillowcase, so I'm not going to take this much further beyond our time. I will only close it on saying this. I know that since 2009, when this was founded originally at McKinsey, I have been inspired by the systems and the leaders that have stepped up and decided to share this openly. I think this fantastic panel exemplifies that leadership quality more than anything else. I would like us all to thank the members of the panel today, and thank you all for joining us in this session. Thank you.